Well, thank you, everyone. Thank you for the introduction, and thank you, everyone, for joining today. So just for disclosures, Alex and I, we do not have any financial or relevant conflict of interest to disclose. And just for an outline, today the plan is really to kind of learn about the overview of G6PD, the history of the discovery, what is it, how do we screen it, what is normal versus abnormal activity when it comes to the testing, and also we will dive into the relationship of Dapsone and G6PD deficient patients. What kind of drug-gene interaction is there, and how can we avoid it? And the case is specifically about a solid organ transplant patient. So this will be our focus. And then we will end with the case presentation, discussion, and questions. One thing to mention is the focus is purely clinical. So we did not really dive into a lot of details as far as like the lab information, and some of them we also do not have. But feel free to ask questions, and we'll be more than happy to answer what we know. Okay, so I thought for fun, usually we just start right away with the scientific information. So I found this very, good article that talked about the history and the background of G6PD deficiency. So it was actually discovered in 1891 through the discovery of methylene blue, which another medication that's actually should be avoided in G6PD deficient patients. And then in 1920s, when actually they discovered primaquine, which is another also high-risk medication in G6PD deficient patients, this made a significant advancement because, as you know, Dapsone and primaquine, they're used primarily for treating malaria. So what happened is in 1950s, this was the beginning of starting like an early mass drug administration. So they gave primaquine to the US troops in malaria endemic Korean areas at that time, which in turn led to the observations of jaundice and anemia, particularly among African Americans. And then with that, they called it primaquine sensitivity syndrome. So until that time, the relationship between the gene-drug interaction was not very clear. Then next in 1962, there was a Chicago group experiments on human volunteers, and the result was acute hemolytic anemia, or AHA, which was triggered by primaquine. They then from there, noticing that this actually happened in patients who had decreased G6PD activity, they really came up with the term G6PD deficiency. Now, please note that, as far as ethical considerations, by today's terms, really this experiment would not be replicated because it really lacked medical benefit for volunteers and there was no consent. However, besides being ethically questionable, luckily there were no long-term ill effects observed. However, also it led to the discovery of the G6PD deficiency gene. Okay. So G6PD deficiency is an X-linked inherited disorder that increases erythrocyte vulnerability to oxidative stress, which basically causes acute hemolytic anemia. And the acute hemolytic anemia is basically where the red blood cells are destroyed faster than they can be made. And the destruction of the red blood cells is what really causes what are called the hemolysis, because red blood cells carry oxygen to all parts of the body. It is most commonly found in populations closer to the equator. So as you can see here, Mediterranean descent patients, African descent patients, and Asian descent patients. Very common in Middle Eastern patients or patients who live by the Mediterranean. So it should always be in the back of our mind if there is a potential medication that will interact with G6PD if you see patients coming from those areas. So when do you consider testing? So I kind of just, as I alluded, pretty much when you suspect, if you see patients who come from African or Mediterranean regions. Also, there are times when you want to consider testing when we're about to prescribe medications, specifically high-risk medications that will increase the risk of AHA, which is acute hemolytic anemia. Multiple medications can pose a risk, and I put here predictable risk of AHA. However, based on the CPEC guidelines that were recently published, we do know that there are higher risk medications that specifically are contraindicated or we should avoid in G6PD deficient patients. And I changed the color of some of the common ones here, and Dapsone would be the one that we will be focusing on today. So as you can see, Primaquine, Dapsone, and Rasburicase is another example too. Okay, so testing. Probably this is the confusing part and the most interesting part of this presentation today. So the deficiency can be tested, can be assessed through multiple tests. The first one is the enzyme activity. And this is a rapid test, probably comes back within 20 minutes to an hour. And really all it tells you is does the patient have a normal activity or are they deficient? There's another test that actually looks at the full gene sequencing. This one takes longer, but it's probably also most accurate for patients. And specifically because sometimes the enzyme activity is actually affected by recent blood cell transfusion, anemia, or if the patient has leukocytosis. So in these settings, genotyping probably would be useful for correlation with the red blood cell enzyme level. Again, here it just shows, so really some of these conditions can mask the G6PD deficiency in some patients. So recent transfusions, or if the patient has high blood count, all of those can interfere with the test, giving you a falsely raising the activity of the G6PD, masking a deficiency. So the patient could actually end up with a normal test result. However, we don't know. It could be misclassified, and we don't know if the patient really deficient or not. Unlike clinically normal patients during testing, the pitfall is the transient substantial increase in G6PD activity. As you can see, timing is critical. So testing occurs precisely when basically when you suspect misclassification. So if you have a patient that's clinically stable and really you're not concerned with any issues, it's okay probably to use the test that's the enzyme activity, that's the rapid one. But if the patient is sick and they're not clinically stable, this is when you should probably make sure that you avoid any test that would give you misclassified information. So timing is critical. It has to be done precisely. And also you want to make sure that if you suspected a misclassified result, like let's say a patient who recently received transfusion is sick and has an infection, and they had a result that came up normal, but you are not sure, it is recommended to actually recheck after 2 months when the patient is more stable and is doing better. Okay, so this is as far as the G6PD deficiency. Now for Dapsone, just to give a bit of a context, just to give a little bit of information in the context of our presentation today, Dapsone has multiple indications. But for the purpose of this case, it is actually used as an alternative for PJP prophylaxis in patients who are in solid organ transplant patients. Specifically, patients who has allergy to sulfa, which is very similar to our case today that Alex will go through here. Another thing to note, and perhaps maybe colleagues who are familiar with G6PD deficiency, despite the fact that it was actually discovered 80 years ago, the literature remains to be very limited. It seems like most of the cases are review cases, and we don't have a lot of case reports, and we don't have a lot of randomized controlled trials that can help us learn more. This is an old, review article that I found. However, I thought, it would be interesting to kind of go through it here briefly because it did have a case that's very similar to our case of our patient. They looked at the Dapsone adverse events in patients undergoing solid organ transplants between 1999 and 2004. They had 16 patients who actually were identified to fit the Dapsone-related hemolytic anemia. 10 of them were females, 6 of them were males, and they had kidney transplant, lung transplant, liver transplant, heart transplant, and some of them had actually a combination of a heart and lung transplant or liver kidney transplant and a heart kidney transplant combination as well. Please note that 12 out of the 16 patients also had sulfa allergies, which that's why Dapsone was used. So here, if you look at our patient population data, I highlighted this, which is interesting because it's very similar to our patient that we found here. But you see, we have a 67 male Caucasian patient. And remember, I told you G6PD deficiency mostly is suspected in patients who are from the Mediterranean region. So most of the time you would expect in Caucasian patients or European descent that, you know, the deficiency would be low, but you always have to make sure, obviously, before prescribing Dapsone. The patient had a liver transplant. The G6PD enzyme level was actually normal. However, the patient actually did have side effects from given the Dapsone. And something that might come to your mind is when you give the Dapsone for a patient and they end up with acute hemolytic anemia, for example, as a side effect, what is the treatment for that? And really the answer is not much besides basically discontinuing the medication and then watching the patient until the symptoms resolve. So here you can see that actually when they started the medication, the patient was actually relatively anemic at baseline, and they've been out of transplant for 29 days. And you can see that actually they did have an event, and really the number of days from Dapsone discontinuation to recovery took around almost 2 weeks. I added here, this is for reference, so CPEC guidelines. This is very helpful because CPEC guidelines specifically has actually a list of medications, and they classified them with high-risk medications, medium risk, and low risk. Dapsone falls in the high-risk medications. And specifically here, you can see for a normal G6PD, it does say, you know, you have a low risk of acute hemolytic anemia. And really, there is no reason to avoid the medication. And this is a strong recommendation. For a deficient patient, it recommends to avoid the use of high-risk drugs, but it also talks about the importance of assessing, you know, the clinical picture for the patient as well, because we want to make sure that the results are accurate. Is the patient really deficient? Is the patient really normal? All are good questions to ask in those post-transplant patients because they are not stable yet. So Dapsone and G6PD dilemma in transplant patients. So as you can see, acute hemolytic anemia complications, although identified 80 years ago, it still stands out as a distinctive case in pharmacogenomics. In this scenario, actually, a specific enzyme deficiency emerges as the sole factor determining a severe and potentially life-threatening side effect. So G6PD deficiency should always be consistently part of our differential diagnosis of AHA, predicting also the side effects of specific high-risk medications like Dapsone in this case. So it's really important to actually recognize the diagnostic challenges in G6PD deficient patients, and you don't necessarily interpret a normal activity result as normal based on what's going on with the patient. And also remember, timely follow-up for testing and making sure it's accurate classification is very, very important.